Um, I can't.
Good afternoon, everyone, and welcome to this webinar on covering COVID-19 vaccines in a responsible manner and evidence-based manner. My name is Lisa Bailey, and I am the PAHO consultant working with the sub-regional office of the Pan American Health Organization. And we have a number of PAHO experts online, and we do also have a special guest as well who will talk to us about managing covering the COVID-19 vaccine as we hope soon to have a vaccine as one of the most cost-effective measures to control the pandemic and also lessen the health, economic, and social impacts. Now, among the main challenges expected for the COVID-19 vaccination is the timely, equitable, and sufficient access. There are also technical and logistical considerations, and then the definition of priority groups, the number of doses, as well as vaccine safety and effectiveness. But added to this vaccine rollout that we're looking to very soon will also be the uptake in target populations in the context of not only a pandemic, but an infodemic, where rumors, misinformation surrounding vaccines has definitely been the case. And there's also been significant coverage in the media, conversations on social media, quite frankly, nowhere can you go without hearing about the COVID-19 vaccine. So PAHO therefore decided that it would make a lot of sense for us to come to you, our essential partners in the media and social media, all of the communicators here in the Caribbean, but also across the world, to talk to you about the vaccines in general, give you an update from the PAHO WHO immunization experts, and we have a number of them online today to talk to you about vaccine safety, effectiveness, procurement, to examine the role of the media in combating rumors, myths, and misinformation around vaccines, and to also strengthen your work, help you to do your work in a way that can help us to not only help you to have more knowledge, but to make sure that the public has the knowledge that they need as well when the time comes to make that decision. So we hope to have Dr. Jarbas Barbosa online. He is the Assistant Director at PAHO WHO. But as I told you, we have a whole slew of experts this afternoon to speak to you about immunization. We're going to start with Dr. Cuauhtemoc Ruiz Matus. He's Unit Chief for Comprehensive Family Immunization, and he's going to be talking to you about a general panorama of immunization programs in the region of the Americas. And then we will move from that presentation then to discuss vaccine basics. And I took a look at this presentation before, and I learned a lot as well. It's all about how vaccines work, their safety and effectiveness, and that will be done by Dr. Lucia Helena de Oliveira, and she's Regional Advisor for Immunization for PAHO WHO. After that, we'll talk specifically about the COVID-19 vaccine. That will be done by Alba Maria Ropero, Regional Advisor for Immunization with PAHO, and that's going to cover what's being done to prepare for this COVID-19 vaccine introduction. Then we'll talk about updates on the vaccine with John Fitzsimmons. He is the Chief of the Revolving Fund Program for Access to Vaccines with PAHO, and he'll talk about the Kovacs facility. I'm sure you've been hearing about that, and the PAHO Revolving Fund under which the vaccine will go. Then we will have a Q&A. And it will be, first, we'll talk to Dr. James Hamblin. He's a staff writer with The Atlantic, and he's board certified in public health and general preventative medicine. He's also a staff writer at The Atlantic magazine, but I'll tell you a bit more about him a little bit later. But we're going to be talking about covering the COVID-19, covering vaccine in general, vaccination stories responsibly and ethically. And then it's all your turn to ask all the questions that you have. So make sure that you note those questions because the Q&A will come at the end of the session. So I'm just going to check now to see if we have Dr. Barbosa online. I don't see him as yet. I can probably take, yeah, he's not online as yet. I'm just waiting on my team to let me know if we can maybe start the presentations. And if he is able to join, we can always have him make his intervention. If that's okay with the team, a nod will suffice. Shall we continue? Maybe start with the first presentation? Yes, that's a good way to let me know that we can start with our first presentation. So we're going to go to that first presentation, just giving you a panorama of immunization in the region of the Americas, and it'll be done by Dr. Cuauhtemoc Ruiz Matus. Over to you.
Thank you, Lisa, and thank you all your participants in this meeting. And a specific thank you to Dr. James Hamblin, staff writer of The Atlantic, to participate in this session. Thank you. The next, please. The idea of this presentation is to show you what is the situation of the program in immunization and take into consideration what is happening with the immunization program in the world. You can see here in these slides that the coverage with vaccines in the child that 1 year old is increasing around all the world. You can see here that diphtheria, polio, measles, hepatitis B, it's increasing in the coverage. And you can see here in the right side of the slide that the deaths, we are prevented a very important number of deaths. You can see here what happened with the vaccine preventable disease in the number of deaths that are in the global level. But you can see here, for example, it's very important, the number of cases that we prevent with the vaccination of measles, for example, more than 21 million of deaths was prevented between 2000 and 2017. Next, please. And if we analyze what is the situation of the coverage in the different regions of WHO, you can here take in comparison what is the level of coverage that we have. In the right, in the red color, is the child that is vaccinated. They receive 0 doses of vaccine. The orange color is the dropout, is some child to receive 1 or 2 doses, but not complete the schedule of the vaccination. the total schedule of vaccination, and in blue is the number of children to complete the schedule. Take a consideration that each country is different, the number of vaccines that we are using. But in general, take in consideration this, you can to see here that the region in the Americas, we have a long history working with the immunization program. The next, please. And in this slide, we can to show you that the America region is one of the most successful region in the use of the vaccination program. First, we was the first region in the world to eliminate smallpox. In that moment, we did not have a national programs like we know now. But after of this, the region of the America was the first region in the world to receive the certification as free of polio in 1994. We was the first region to receive the declaration of elimination of rubella and CRS, congenital rubella syndrome, in the Americas region. We was the first region in the world to receive the elimination of measles in 2016. And with the declaration of the elimination of neonatal tetanus in Haiti in 2017, all the countries in America had the declaration to be free of neonatal tetanus in our region. The point here is what is the next? And we put here that the next maybe is the hepatitis B in the vertical transmission, because we are increasing importantly the use of this vaccine and stop this transmission. The next, please. But the countries in the America are advanced very important in the introduction of new vaccines. And with the introduction of new vaccines, you can to see here what happened in 2000 and what happened in 2017. But you can to see here how the countries in the America are advanced importantly in the introduction of new vaccines. And now the new vaccines like vaccine against HPV, vaccine against pneumonias or pneumococcal, that is the pneumococcal conjugate vaccine, or the vaccine against rotavirus. The America region is one of the regions to have more successful introduction of this vaccine. In this moment, 43 countries in the America region, countries and territories in the America region are using vaccine against HPV. 27 countries are using PCV, that is for pneumococcal conjugate vaccine, and 22 countries are using rotavirus vaccine to stop some types of diarrhea. The next, please. And the impact of this program in the Americas about the morbidity, for example, we show some deaths what we save when the use of measles, for example. But about the morbidity here, we try to compare what happened before the vaccination and what happened after the vaccination that we have. We can to see here, we're free of polio. The number of cases of rubella, we have cases only that it's coming from imported cases. We have 0 cases of CRS. We have a very, very small number of diphtheria. In this moment, we have only transmission in Haiti and in Venezuela in some specific cases. And we have a very small number of pertussis, and neonatal tetanus is really, really low. And the measles you can to see here, but the last year we have more around 20,000 cases, but their cases are linked principally with the outbreak that we had in Brazil. The next, please. But what happened in the last 10 years in the America? You can to see here what is the coverage that we had in all the regions in the WHO regions. And the orange line here is showing us how the America is decreasing in the coverage that we have if we take in consideration the third doses of DPT, the vaccine to contain DPT in the Americas. The next, please. But in this slide, you can to see here the report that we have for the coverage for different vaccines that we use. You can to see here, for example, that the BCG, our DPT1, it's around the 89%, or the polio, the first doses of polio is around the 89%. But the third doses of the vaccine to contain DPT3, it's 83. This is showing us how we have a problem in the countries that we can to apply the first doses, but we cannot complete the total schedule. With the data that we have in America, about 25 children trees are completely left behind, while one start and 3 doses and one start the 3 doses scheme and does not finish it. In comparison with other regions in the world, really we are in good level, but it's necessary to reduce the gap that we have yet. The next, please. But why the America region is had this number of doses? You can see here that there is a big countries like Brazil, Mexico, Venezuela, Argentina, that unfortunately are increasing the number of children that not receive the complete scheduled vaccination. There are different reasons for this. But in this link that we show here in the slide, you can look what is the report for each of these countries, and this is the winning report that is created by the report that is coming for the countries. And we need to work to reduce this gap that we have in these countries and in total in the region of the America. The next, please. But it's important to know not only to have the information what is happening at the global level. We look what happened at global level, what happened at national level, but it's necessary to analyze what is happening at the local level. And this slide can to show you that what is the information that we had now about the municipality level. And it's necessary that to maintain high coverage and homogeneous coverage into the countries to maintain the elimination of the disease or to maintain in control the vaccine preventable disease. The next, please. But one point is what is happening with the program now in the pandemic time. This is a survey that we had with the focal points for immunization program or PAHO immunization program in the countries. And you can see here that at the beginning of the pandemic, we have a very important affectation of the immunization program. And the impact of this give us that between May and June, around more than 90% of the demand in the countries were reduced in the number of the demand that we have. Now, the impact is important because the people don't like to go and to have the risk to infect in the health centers or to go out of home and to have the risk of this pandemic. The next. And obviously, this is impacted in the coverage. This is a report that is coming from 25 member states in the PAHO region. And you can see here the comparison between the number of doses of measles and mumps and rubella vaccine in comparison month by month, April, May, June, and the number of percentage that reduce in the number of doses what we apply for this vaccine, again, measles, rubella, and mumps. This is obviously the impact of the pandemic. Next, please. But with this, we have a lot of challenges. And the challenges is not necessarily into the health service. The challenges, it's sometimes out of the health service. I think that we need to discuss this and to maintain the immunization program in the high level in the political agenda in all the countries. The urbanization, the natural disasters, the political situation in the countries, the lack of equity, the movement that we have of the population, the financial crisis that we had in all the countries is a challenge that we maintain. But here it's really, really important your role and your support to maintain the confidence of the vaccination in the countries in the America. The next, please. And thank you. You have the link if you need more information. Thank you, Lisa.
Thank you very much, Dr. Cuauhtemoc Ruiz Matas, for that panorama of immunization in the Americas. Happy that you started on a good note there is good news. It's good to have good news in these times. We do have a long history of success in terms of immunization, but then also talking about the numerous challenges and the current impact of COVID-19 on immunization. We are now really happy that we can welcome our Assistant Director, Dr. Jarbas Barbosa, who was not able to join us for the welcome, but I'm sure that he's happy to be with us and would like to still say a couple words. Dr. Barbosa, over to you.
Well, thank you. Good afternoon. And sorry, because I received a urgent call that I need to take. But I could see part of this very interesting presentation from Cuauhtemoc. I would like to welcome all the participants in this webinar for journalists and communicators, where we will be providing an update on the COVID-19 vaccines and discussing how to promote responsible and evidence-based news coverage related to the vaccine. As you know, the world hopes soon to have a COVID-19 vaccine or vaccines as one of the most effective measures to control the pandemic and to reduce the public health, economic, and social impact on our populations. However, once the vaccine is available, ready and available for distribution, it will be rolled out amid a series of important challenges. Among them, first, ensuring equitable, timely, and sufficient access to the vaccine, addressing technical and logistic aspects, such as the development and production of vaccines, some of them utilizing very innovative technologies, defining the priority groups to receive the first vaccine doses, and determining the appropriate number of doses for adequate protection. Additionally, vaccine rollout and its subsequent uptake is targeted populations will be carried out within the context of the infodemic and misinformation surrounding the COVID-19 vaccine. Even though the COVID-19 vaccine has not received the regulatory approval for its use in the population, there has already been significant media coverage, conversations on social media, and speculation on this topic. Widely circulating myths and misinformation increase the risk that people will choose not to seek out the COVID-19 vaccine as recommended when it becomes available, and may also contribute to individuals losing faith in routine immunization programs, thereby putting the population at risk of contracting vaccine-preventable diseases like measles, pertussis, and polio. Concerned about the safety and the efficacy of a new vaccine developed in record time, rumors put forth by anti-vax groups, and the dissemination of information not based on scientific evidence, and also the political polarization, all have the potential to create barriers to vaccine uptake when the vaccine is available. As members of the media and communicators, we do believe that you need to play a very important role in dispelling any myths and falsehoods surrounding the COVID-19 vaccine. And as such, protecting the health of your community is vital. We do believe that since the very beginning, PAO has been working to communicate transparently what we know and what we do not know about COVID-19 in order to clarify misunderstandings and to debunk rumors. However, we cannot do this alone. We do believe that your participation will be very important. I have no doubt that the best way to overcome any kind of hoax, rumors that are disseminated is when we provide information based on scientific evidence that we have, and also when we are providing all the information in a very transparent way. People have concerns and we need to take them into account. We need to provide the information. We need to encourage the Ministry of Health to explain what they are doing, what are the steps that they are performing, also in a very transparent way. We can see from many information that the people sometimes they don't understand what are the steps that every vaccine has to perform before being released and before being recommended to be used, all the clinical trials, the regulatory aspects, the post-market surveillance. So there are many important aspects that we can contribute, we can provide information, the national health regulatory authorities and the Ministry of Health also working together can provide all this information in order to have people receiving data and information and facts, not the opinions or rumors, and they can make their own informed based decision. So we are counting on you also to support and to participate at this crucial time to help us get the scientific facts and evidence out to your respective audience. By doing so, you'll be saving lives. Thank you for your participation. I wish a very, very good webinar for all the participants. Thank you.
Thank you very much, Dr. Barbosa. We're happy that you were able to join us to bring those very important remarks. Yes, the best way to combat rumors is with information, and information can save lives. So thank you very much for that. We're going to continue now after learning a bit about immunization in the Americas, the history and where we are now. We're going to move now to vaccine basics. How do they work? Talking about their safety, their efficacy, and their effectiveness is Dr. Lucia Helena de Oliveira. She is Regional Advisor Immunization at PAHO WHO. Over to you. Dr. Lucia, you're still muted. Please unmute.
Just unmute.
Sorry. Thank you, everyone, and thank you, Lisa. Could you please move? So in the next 20 minutes, I'm going to present some general concepts about vaccines, how the vaccines work, vaccine development, what are the phases of clinical trials, the landscape of the COVID vaccine, and some aspects regarding vaccine hesitancy. Next. So I'm going to talk in general about vaccines, but all the concepts that I'm going to talk here, they are applied to the COVID vaccine as well. So vaccines prevent disease that can be dangerous or even deadly. They greatly reduce the risk of infection by working with body's natural defense to safely develop immunity to disease. In other words, vaccine is a part of a germ that is exposed to your immune system in a safe way so that it can learn how to fight off that harmful pathogen and protect your body from it in the future when this pathogen enter in your body. The World Health Organization says that that vaccines prevent, at least 10 million deaths worldwide between 2010 and 2015. Next, please. Quickly, I'm going to tell you how the vaccines work. So vaccines help develop immunity by imitating an infection. So the vaccine does the same thing that the virus or the bacteria would do if it entered in your organism. Once the imitation infection goes away, the body is left with a supply memory. And this memory will be activated when the germ, the virus or the bacteria, for example, enter in contact with your body. So that will remember how to fight with this disease in the future. Something important, sometimes after getting a vaccine, the imitation infection can cause minor symptoms like fever, for example. So many people, when they get the shot, they say, I got the disease because I have some kind of fever and some kind of symptom, but it's not true. It is your body, this is working with this vaccine in order to prevent the disease. But this work that your body does is similar if it will do with the disease. So, and also it's important to mention that it takes a few weeks for the body to produce antibodies. And it means many times it's possible that a person infected with a disease just before or just after the vaccination could develop symptoms and get a disease because the vaccine has not had enough time to work. So this is another situation that sometimes occurs. The person gets the shot and gets the disease. And so it's possible that the vaccine didn't have time to do effect, so the disease will occur, or it was you get the disease before to take the vaccine. Next. Let's talk about vaccine development. Usually, this process is very large and complex, often lasting 10 to 15 years. And in this situation now that you are, and we are talking about this later, my colleague, Alba Maria, this vaccine will be produced, the COVID vaccine will be produced in much less time. It doesn't mean that the vaccine is not going to be secure and it's going to be safe, it's going to be safe and efficacious, because there are a lot of protocols in this moment, protocols from WHO, protocols from FDA, protocols from EMA that are established rules and for this vaccine, which is going to be produced in a much shorter time, because this vaccine probably are going to, the vaccine or vaccines you are going to have in probably less than 2 years. I'd like to show you here something that everyone is talking about at this moment, about the platforms of the COVID vaccine candidates. So the COVID vaccines are using platforms that were used in the past, like virus vaccines or protein-based vaccines, but also are using novel platforms, which are the viral vector vaccines and DNA and RNA. The viral vector vaccine, for example, there is just one vaccine that uses this platform, which is the Ebola vaccine. And for the DNA and RNA, none of vaccine at this moment has been producing using this kind of platforms. So you can see that for this COVID vaccine, we have a lot of different platforms, including the old platforms and novel platforms. The next. Also, it has been in the media, and everyone talk about the phases of the trials of the vaccine. Before a vaccine to be licensed, we have 3 phases during the clinical trial. We have the preclinical trial, and during the clinical trial, we have 3 phases, phase 1, 2, and 3. The phase 1 is a very small scale number of people that we have. It usually is like 20, 30 people. And in this phase, it's tested on safety, doses, and efficacy of the vaccine. If everything is okay, we are going to go to the phase 2, where you are going to have more people in this clinical trial, usually hundreds of people, 100, 200, and we are continue testing for safety and efficacy of the vaccine. In the phase 3, which many vaccines are right now, COVID vaccines, is a large-scale trial, and tests expanded to thousands of people, with some receiving a placebo to test for safety, doses, and efficacy, as well as side effects. So during the phase 3, we have people who received the vaccine and people who received the placebo. And at the end of phase 3, you are going to compare what happened with the people who received the vaccine and what happened with the people who received the placebo. With this comparison, we can analyze the data and verify what is the efficacy of the vaccine, for example, and also if the vaccine is safe or not. After phase 3, when everything is okay, the numbers are with the way that you are expecting, the vaccine has to be approved. So the regulatory agencies in the countries will approve the vaccine based on results of the trials. In some cases, as I mentioned before, for the case of the COVID vaccine, countries may authorize emergency use before trials completely are complete. Next, please. So everything's okay until phase 3. The vaccine was approved by regulatory agencies and WHO pre-qualification, for example, or used for emergency. And then we are going to go to the phase 4. And phase 4 is the phase that you use the vaccine in the real world. So if everything was okay in the phase 3, this vaccine will be distributed to the immunization programs in the countries, but we are going to continue during this time, which is the phase 4, monitoring safety, and also you are going to see how the vaccine works. And then we are going to do the studies about impact and effectiveness of the vaccines. Next, please. The landscape of COVID vaccine, October 15th. This graphic changed all the time. Usually this graphic is from, the numbers are from the WHO web page. And probably today they are updating because they update once a week. So on October 15th, we had 198 candidate vaccines. In preclinical evaluation, 156, phase 1, 25, phase 1 to 19, phase 3, 10, and none of them approved. So this is the state of the COVID vaccines at this moment. We don't know which of these 10 vaccines in phase 3, if they are at work according to expected or not. But this is the situation right now. The next, please. Let's talk about vaccine hesitancy. First of all, I'm going to give you the concept. What is vaccine hesitancy? Is the delay in acceptance or refusal of vaccines despite availability of vaccine services. Vaccines hesitancy is another process, very complex with context specific, invariant across time, place, and vaccines. So sometimes you have problems with one vaccine, sometimes you have problems with another vaccine, sometimes you have problems in one country or in one region, and then you're going to have problems in another country, another region. And it is influenced by factors like complacency, convenience, and confidence. So we have to improve vaccination demand in order to address hesitancy. So addressing low vaccination requires an adequate understanding of the determinants of the problem. We have to know in each country and about which vaccine and when, what is the problem and what is the situation that is generating this kind of hesitancy towards a vaccine. Next, please. So in order to avoid, in order to handle the problem of the hesitancy in vaccines, we really need your help. Your job is critical to maintaining vaccine confidence in our population. As Dr. Jarbas mentioned in his speech, your job and to have you working with us really, really makes the complete difference. Next, please. I'm going to talk about some of the myths. I'm not going to talk about all of them because there are a lot, but I'm going to give some examples. For example, we don't need to vaccinate against rare disease. Why people say this? They say this because they haven't seen the disease in the last years. And why they haven't seen the disease the last years? Because all the children are vaccinated, so we don't have the disease anymore. But if you stop vaccinating, you are going to start to do the same disease again. Like, for example, measles, diphtheria, whooping cough. Another one, mercury makes vaccine risk. This is not true. There are a lot of studies that have shown that mercury is not a problem in the vaccines because the quantity is very, very, very small. And mercury has been used as preserving agent in some vaccines since 1930s. According to CDC, no harmful effects have been reported from the use of mercury in vaccines. Next. Vaccines cause autism. This is one very, very, very famous. Everyone was talking about this one. Unfortunately, this myth, which was from decades ago, was based in one study, just one study, which was found to have been fraudulent, and the head research was paid to make the connection between autism and the vaccine. After that, many other research have been doing, and all of them didn't show any link between vaccines and autism. Next. So now I'm going to talk about just three myths of vaccines. All of them are in our webpage. You have the link here. And in our webpage, debunking immunization myth, you have many myths about different vaccines. Some examples. Will giving a child more than one vaccine at a time overload their immune system? No. The scientific evidence shows that giving children several vaccines at the same time has no adverse effect on their immune system. And also, there are many key advantages. For example, the children don't need to go to the health care many times because he or she is gonna take the vaccine, many vaccines in one's time. Fewer injections, which is very good too for the child. So this is actually very good for the children, and not the opposite. Does the HPV vaccine make you infertile? No. Although this myth has received a lot of attention in the media, the Global Advisory Committee on Vaccine Safety from WHO has conducted an extensive systematic review about all evidence available and conclude there is no relationship between HPV vaccination and infertility. Actually, about the HPV, there are a lot of myths. And so I invite you to go to our webpage and see all of the myths and all of the answers to this myth. Is flu like a cold? Seasonal influenza is characterized by initial symptoms with high fever, cough, chills, muscle and joint pain, but could require hospitalization, and many times can even cause death. And cold is caused due to other virus, and the symptoms are much lighter. Next. So here you can see all the reference that I used for this presentation, and you can have more information. And of course, I'm completely available for questions that you have after the presentations. Thank you for your attention, and don't forget, we need your help. Thank you so much.
Thank you very much, Dr. Helena de Oliveira, for the vaccine basics. I learned something for sure. And as a mom, I did have that question about, all of these vaccines at one time, how does that impact on a child? But I do see the good in it, not having to go back too often. And then, of course, the HPV vaccine, there have been a lot of questions about that as well. So remember, you can put your questions in the chat box from now. I don't want you to try to remember them all. The Q&A box is there. Please just give us your name and your organization and put them in the Q&A, and we will direct them to the advisors. And we also have someone on who can talk to you about actually covering these issues as well. So please put them in the chat box from now, and we will get to them. So from vaccine basics, now we move to preparations for this COVID-19 vaccine introduction. And this presentation will cover what's being done to prepare for the COVID-19 vaccine introduction. It will be done by Alba Maria Ropero, Regional Advisor for Immunization with PAHO WHO. Please welcome her. Thank you.
Thank you, Lisa. Good afternoon to everybody. The next one, please. For this presentation, I will cover the planning process that countries, the Ministry of Health, are considering in the introduction of this vaccine. They have to consider the allocation of the vaccine, prioritization of groups, and specific vaccine recommendations, and also vaccine acceptance, as Lucia just mentioned, and next steps. Next one. As we are planning, we have many questions, but countries have to move faster in order to plan in advance. Even we don't have all the answers. We know that at this stage, we don't know if which vaccine will be successful, the vaccine efficacy, the duration of the protection, the vaccine supply, number of doses required, 1 or 2 doses, the priority groups, the cold chain requirements. We know right now that some of the vaccine will need maybe ultra cold chain, others will be the normal cold chain requirements, the co-administration, but especially the infodemic and vaccine hesitancy and politicization of the pandemic. We have a very complex context in a pandemic with a huge impact in social and the economy impact of this pandemic, but we need to move forward and plan in advance in components that we can do that. All of these aspects that you see here, that will be part of your interest to publish, to educate the population in order to have well-informed the community. And as soon as we are having more information, that will be nice to have that kind of a collaboration with all of you in this process. Next one, please. Talking about vaccine allocation, given the scenario that we have now, that we will have a very short or limited vaccine available at the beginning of this process, at global level, there is a Kovacs facility process that they have already prioritized or give some estimations in order to have equity distribution of the vaccines for all countries participating in the Kovacs facility. I want to expand in this process because John Fitzsimmons later on is going to explain what is the Kovacs facility. But for this presentation, I want to highlight here that the idea is to give vaccine at least to cover 20% of the population in each country. 3% of this vaccine will be for the healthcare workers, and 17% will be for people with chronic diseases and the elderly. This is because we have people affected, healthcare workers, they themselves are very affected for the pandemic, and also they are the ones giving care of the patients, and then we need to protect the health services and the society working. And we need to protect the elderly and also people with chronic diseases because they are the one with the highest mortality due to COVID, the virus, with this virus. This is the information that all countries have already in place. They are planning to at least to vaccinate at the beginning of the vaccination campaigns, at least this 20%. Next one. Now, in addition to the Kovacs allocation, we have recommendations from from WHO and our strategic advisory group, which gives recommendations to countries in order to have vaccine values. There are 3 steps here. One is they developed a values framework to help countries to prioritize populations. And also they developed a roadmap, which is the idea is to help countries to build scenarios given the limited supply availability, and also given the epi situation, the epidemiological situation, they have to build that kind of a scenario in order to see how they can prioritize and who could be first to be vaccinated. And the vaccine-specific recommendations, which vaccines for who, this is the most important part of the recommendation for countries to vaccinate, but that will be based on the evidence when the clinical trials that Lucia already mentioned finished, and they will have the recommendation from them, and then we have the pre-qualification, and this vaccine has been licensed, and then in that moment, a country can start using the vaccine in those groups. But this is a three-steps group, a three-steps process. One is giving countries and at global level as well values and principles in order to help for this prioritization. This was published in September 14. The prioritization roadmap was published in October 20, just this week. And we are waiting for the vaccine recommendations. Next one. These are the values: human well-being, global equity, reciprocity, equal respect, national equity, and legitimacy. These values can be applied for each group, and then the country and the NITACs, the advisory group at national level, can help the Ministry of Health define groups using these kind of values in order to select or prioritize groups. Next one. And the roadmap help countries to define the scenarios, as I mentioned, given the vaccine availability and also the epidemiological settings. There are some assumptions that this is published here in this link. There are assumptions that we'll have vaccines pre-qualified, that will have vaccine efficacy, very good efficacy for different groups, and etc. And also we have dimensions for this prioritization. For example, the epidemiological scenario, if there is a community transmission of COVID, or there is a cluster transmission or no cases. Next one. We have here the scenarios. We have community transmission, sporadic or clusters, and no cases. The idea is that when countries are doing their plans, they have to consider all of these aspects at local level and national level as well. Next one. And also the limited vaccine supply that we'll have. The stage roadmap consider 3 stages. They consider a very limited vaccine availability from 1 to 10%, limited vaccine availability from 11 to 20%, and the stage 3 over 20% availability. These are the scenarios that countries have to think about it, because we won't have vaccine for everybody at the beginning. They have to prioritize, and they have to think about and combine all of these factors. Next one. And this is an example how they can prioritize a specific populations. I mentioned at the beginning that healthcare workers is one of the main group or the first groups to be prioritized. They are, and also the scenarios, you see here the community transmission, but countries have to consider any scenario at that moment. And then the stage 1, when countries have only from 1 to 10, they have to select or to prioritize healthcare workers, because they are a very high risk for acquiring and transmitting the infection. And also they help to protect the health system. They are the ones who have to attend to the patients. And then there are many reasons to prioritize healthcare workers. And then they have here, these are the same logos for the values. They consider the well-being, and they consider also reciprocity, because they are also doing a lot of work in order to protect the society. And then this is a way to protect the healthcare workers as well. This is very important, because how countries prioritize a group, they have to discuss this with the national advisory group and with the Ministry of Health in order to prioritize, and this is the rationale that they have to do with this process. And also in this stage, they should prioritize the older adults, because the mortality is very high. The other stages is based on also in vaccine availability, and then they can include other groups and other high-risk groups based on the country situation and the local context. And the stage 3, when we have more vaccine, more than 20%. Next one. Now, mentioning the vaccine acceptability, that this is very important, and Lucia already mentioned this. Next one. And then there is a, yeah, thanks. There is a survey conducted in almost 70 countries in order to know the acceptability of the vaccine. And this is the region of the America. We have some countries in this survey conducted for Johns Hopkins University, and then we see a very good acceptance in the Americas still, but there are some countries that the acceptance of this vaccine is not very high. This is important, and that's why you have a critical role in order to help us and to help the community to know about the importance of the vaccination and be vaccinated when the vaccine is available. Because there are a lot of efforts at global level in order to develop vaccines and to stop or to control the pandemic. And then when the vaccine is ready, many people are not getting the vaccine. And this is why we think that you have a very important role to play here. Next one. Just this is a slide to remind you that during the pandemic, H1N1 pandemic, we had a very tough time with a lot of rumors, and the uptake of the vaccine was jeopardized, and not many people were vaccinated, and they were dead because they didn't accept the vaccine based on these rumors and all of these social and communication crises that we had. That is only a reminder for us to keep in mind that we have lessons learned here. Next one. In the meantime, Lucia already mentioned this, that we need to work in order to avoid myths, transmitting good information. And we right now have been working in order to promote influenza vaccination in the context of the COVID. And more than 100 million people have been vaccinated in the region of the Americas so far, especially in the Southern Cone, because not because influenza vaccine protects against COVID, but because we need to protect against flu and also avoid hospitalizations and cases for flu. And we need to free up the health services to attend COVID patients. That is the kind of messages that we need to transmit to the community as well. Next one. And finally, we would like to mention here that countries have to conduct a very good country communication campaigns in order to be very clear on the objective of the campaign. If the objective is to reduce morbidity and mortality and keep essential services working, and then they need to prioritize healthcare workers, people with chronic conditions, and also elderly. But how to transmit this information to the population, this is also critical for you and for us to help us in order to transmit this information, and also to have the trust of the community in a planning that should be transparent from now to the implementation. And that will help us also to have the adherence of the population. And also the importance of addressing infodemics with good sources and good information to the population. Next one. And some resources that we will leave in the presentations. Next one. And this is the message of Dr. Etienne, the importance of planning and also the misinformation that is affecting all of us. And then that is why we are here with you, and we are counting on you today and for the whole process in these months and next year to come. Thank you so much.
Thank you so much, Dr. Alba Maria Ropero, Regional Advisor with PAHO WHO, for preparations for the COVID-19 vaccine introduction, telling us exactly what is vaccine hesitancy. We hear these terms a lot, but actually explaining what it means, and then how prioritizing vaccines will work, and that it is very much contextual and country-based, and there are a lot of things to consider. I do see the question from Trinidad. Trinidad has already started asking some questions. Please remember to put your questions in the Q&A. We do see them. In terms of communication, you see that Alba Maria already touched on communication, and we at PAHO are very sure that we know that we have to make sure we do our part in communicating on this so as to try to get rid of this vaccine hesitancy, because we have seen that the evidence is there that vaccinations have worked through the years. So we're going to move now to Mr. John Fitzsimmons. He is the chief of the Revolving Fund Program for Access to Vaccines with PAHO WHO, and he's going to be giving us an update on vaccines against COVID-19, the Kovacs facility, and the PAHO Revolving Fund. Over to you, Mr. Fitzsimmons.
Thank you, Lisa. Good afternoon, everyone. I hope you're having a good day and enjoying the presentations by all our colleagues here today. As Lisa described, I'll provide an update on vaccines against COVID-19, the Kovacs facility, and what we've been doing at PAHO to help support member states in the Caribbean and throughout Latin America to access this new vaccine. Next slide, please. Next slide. So just so we're all on the same page, there are currently no vaccines available to date. And you have in the link here a reference to the landscape of COVID-19 candidates. The information I'm showing here in the slide is from that link, and you can easily follow this information on a weekly basis. The link is normally updated every Tuesday. What you see here in the left box are the different platform of vaccine products that are currently under development. Inactivated, non-replicating viral vector, RNA, DNA, protein subunit, VLPs, etc., and the number of products in the various clinical phases that are shown there, 6, 12, 6, etc. And then to the right, the number of candidates by phase, clinical phase. So there are 10 candidates currently in phase 3. That is the most advanced phase. So there are continuing reports, media reports in the news, international news on these advances. And one of the key things for PAHO and WHO in general, in terms of working with the facility, is to assure with the national regulatory authorities that the vaccines being under development are safe and efficacious for use. Next slide, please. How do countries access these vaccines? Well, there are three general options. One, nationally. Two, as a group. Three, as a global mechanism. So in this hemisphere, you've seen in North America many deals that have been done. You've seen information in the media about Brazil and its arrangement with suppliers. You've seen information in the media about Mexico and Argentina about their engagement with suppliers, respectively. That's the national access mechanism, box A, in which countries negotiating deals with manufacturers individually to lock up supply agreements, generally for their national markets. Then you have the grouped access mechanism, which may be groups of countries such as the European Union as one such group. And then there's a global access mechanism. Here at PAHO, we've been looking at the global access mechanism and working with our colleagues at WHO, at Gavi, at CEPI to help make this a reality for the countries of the region here. So our PAHO Revolving Fund has been strategically placed here since the early days of the design of this facility until the present. And we feel that this gives us the best opportunity for equitable access through fair allocation across countries. And just imagine you've got a basket of vaccine candidates that are, and I'll get into this a little bit later, that are currently 9 candidates from those different platforms. Hopefully all of them are successful. Some of them may not be successful, and we'll know in due course. And so the opportunity for success is improved through this mechanism. And that's not to say that the other options aren't important options for countries. And we're just saying that we feel that this is the better opportunity. Next slide, please. So here's some general information about the Kovacs facility. Next click, please. So on the right, you have these 3 pillars that form part of the access to COVID-19 tools accelerated. You've got the vaccine pillar, the diagnostic pillar, and the therapeutic pillar. We're focused here today talking about the vaccine pillar and our engagement with CEPI, which is managing this work stream of vaccines in development and manufacturing, WHO, which is overseeing the policy and allocation principles for successful vaccine when they become available. And then the blue work stream is the procurement and delivery at scale, which is led by our partners at Gavi. That's where the Kovacs facility currently sits. As I mentioned, we've been engaged in the design of the facility going back to the first quarter of this year. And we've approached the facility as a block, as a regional block, and as the procurement mechanism for this region. UNICEF's supply division, which is located in Copenhagen, is the procurement mechanism for the other regions of the world. So we're working closely with UNICEF in terms of our engagement with Gavi and the Kovacs facility in terms of eventually bringing safe and efficacious vaccines to countries of this region. As in the second bullet, the objective is to accelerate equitable access to appropriate, safe, and efficacious vaccine for all countries, regardless of their income classification. And this is important because I think, as Alva Maria mentioned, or in reference to the H1N1 influenza pandemic back in 2009, there were certain challenges around that, and not all countries were treated equitably. Not all countries had equal access to the pandemic influenza vaccine H1N1 at that time. So we're optimistic that the lessons learned from 2009 and 2010 will bear fruit for us here in 2020. Having said that, the participating countries that have these bilateral agreements that I was mentioning earlier on the previous slide can also participate and benefit from this facility. So Canada is one of those countries that has a number of bilateral agreements. I mentioned Mexico, Brazil, Argentina, all have bilateral agreements. They also have agreements to access vaccine through this facility. So for them, in many ways, this is an insurance policy. If my individual deals don't work out, I can come over to the Kovacs facility and get in line and access vaccine through the Kovacs facility. The Gavi Secretariat is the legal administrator, and some 92 countries within the scope of the engagement, 10 of which are located in this region, will also receive additional support in terms of in many respects, subsidized vaccine in terms of the price. Vaccine that's when it becomes available. So just to mention that. And in the Caribbean, those countries include Guyana, St. Vincent and the Grenadines, Grenada, Haiti, Dominica, and one or two others. We have that list and we're happy to provide you with that list so, as a reference. Next slide, please. So as I was mentioning earlier, equitable access and allocation. To follow on Maria's points, we're focused here on phase 1, that's 2021, and ensuring proportional allocation to countries to access to their initial 20% of their population, targeting health and social care workers, targeting high-risk adults, or other important risk groups that countries and national immunization programs may identify. Next slide, please. And what is the revolving fund? So before COVID, the revolving fund at PAHO has been in existence for about 40 years. And it's been servicing the countries of the region, 42 countries as shown here, in accessing vaccine at affordable prices. What we do is pool the demand, all the countries in the region, big and small, and as diverse as we are, pull that demand together. That consolidated demand then transitions into international bids that suppliers are attracted to because of the volumes that bring lower prices for our countries. So if you were to look at our price list and compare it with others globally, you'll be surprised at the price difference. This is important because it speaks to the sustainability of our national immunization programs. With that in place as one of the backbones to the regional immunization program and to the national immunization programs in the countries throughout the region, again, big and small, countries have achieved significant successes over the years, as you probably heard from Dr. Ruiz Matos in his earlier presentation. Last year, just in terms of some data points, the revolving fund purchased on behalf of the 42 member states in the region, approximately $780 million worth of vaccine. And we have a working capital fund of about $215 million at the close of last year, December 2019. That working capital fund is important because it serves as a credit card for countries to advance purchase and access vaccines earlier than having to wait and pay suppliers, et cetera. So it's been an effective tool over the years. We continue to look for opportunities to improve it as an operation and in service to our member states. Now, COVID has come along, and I'll be frank with you, it's been a challenge these last 4 or 5 months, as I'm sure you've been challenged and many others have been challenged in this pandemic. Next slide, please. So what have we been doing? I mentioned that we presented ourselves as a regional bloc. We have 2 groups within that bloc. First, on the left side are the advanced market commitment eligible economies. These are the 10 member states that I was referring to earlier: Dominica, Grenada, Guyana, Haiti, St. Lucia, St. Vincent and the Grenadines, among others. in Central America and South America. And they will benefit from subsidy coming out of the facility in order to access their vaccines. And on the right side are the self-financing countries. Those are the other 23 member states and territories that make up the 42 member states that participate in the revolving fund. And as I mentioned earlier, we're just part of this larger technical cooperation package of services that PAHO offers the national immunization programs throughout the region. Over the last 2 or 3 months, the self-financing countries have signed commitment agreements. Trinidad and Tobago, Barbados, and many others have those agreements in place. We're currently working with these 27 countries to begin implementation of these agreements with some of the initial down payments that are required by the facility. And so I have the reference here to the 2 types of agreements. 19 countries have the committed purchase arrangement, and 8 countries have the optional purchase arrangement. In the optional purchase, this is in reference to those countries that may have the bilateral deals that I was mentioning earlier: Argentina, Brazil, Mexico. And some of the Caribbean territories and Suriname also have optional arrangements. Suriname and some of the other Dutch territories may benefit from support in the Netherlands. Some of the British territories in the Caribbean may benefit from additional support from the UK. So they have the optional arrangement. In terms of the committed purchase arrangement, those are the other 19 countries. And we're currently working with them closely in terms of their initial management of the new agreements. Next slide, please. To give you a feel for the magnitude of the costs associated with the new vaccine, and this is based on an average price per dose, a weighted average price. Again, we have this basket of vaccines, right? We don't know what's going to be successful yet. The estimated average price in terms of engagement around the facility is $10.55 a dose. We're expecting 2 doses to have to be administered to the high-risk groups that Alba Maria was talking about earlier. So for our 28 self-financing countries, our 10 Kovacs AMC eligible countries, plus Brazil and Mexico, our rough estimate of cost projection based on the assumptions that I provided is $2.7 billion to cover 20% of the population next year. Where's all that money going to come from? How is that going to be financed? That's one of the challenges for all of us. And it's critical thinking about therapeutics, diagnostic, vaccines, and these different tools, the financing around these tools to get our countries back up and functioning, irregardless of income level. The total quantity of vaccines that were estimated here is approximately 273 million doses. In addition to the vaccine, there's the issue of syringes. The majority of the platform vaccines in development will require syringes. And so we have an estimate here along the same lines of the assumptions, two doses per person, right, you can see the number of units of syringes taking into consideration a wastage rate of about 10% of 285 million syringes. There's pressure, not only vaccine suppliers and development from around the world, but also syringe suppliers and identifying sufficient quantities of syringes for the application of these new vaccines. And this is one of both of which are a challenge for us, and we're working around the clock together as an organization and with member states, the ministries of health, to help make this happen. Next slide, please. And what have been some of those milestones that just to give you a flavor of the processes over the past few months? PAHO, as a health agency of WHO for the region, and as a UN agency, has a directing council in which all the ministers of health from all the countries, North America, Central America, South America, all participate in this directing council. The last one was held late last month. And as part of the resolution that was passed, the member states, the ministers of health, asked our director to support all member states in engaging in global initiatives such as the Access to COVID-19 Tools Accelerator. So that's our mandate, and that's what we're working to do. And then you see here through September, October, and into the latter part of this year, some of the milestones that have been achieved. I mentioned the commitment agreements, the 27 self-financing countries. I mentioned the execution of commitment agreements. I mentioned the advanced market commitment countries. Today, in fact, everybody in this room or around this table with you today participated in a briefing of the 10 AMC member states on their processes. They don't have agreements in place just yet because they will be receiving financial support, whereas the self-financing countries, as the name implies, are providing their own support, either from national budgets or from other international financing sources. And in addition to working with the 10 countries on their applications now, we're also engaged with our colleagues in the UNICEF Supply Division in issuing a request for proposal to those vaccine suppliers that I was referencing earlier and issuing an international tender. We have a deadline of next week to release this joint request for proposal with our colleagues from UNICEF. And so after this call, that's one of the things that we'll be looking at, getting that out and getting that to colleagues at UNICEF in Copenhagen so that they can review the changes that we've been making in this request for proposal. And we also have other items to be looking at through November and December, which are shown in the top box there. Next slide, please. Some of that gets back to planning and working with our colleagues at WHO in Geneva on their allocation portal. This is eventually should be a digitized platform. And so we're providing some guidance on that, as well as looking at our own demand platform to help work with countries here and also relate to country level tools. And I mentioned the international tendering process, which is shown here in item 3. Two key items regarding that tendering is the issue of indemnification. These are new products. What are the risks? How do countries work through those risks? How do suppliers work through those risks? And regulatory harmonization. Every country has a national regulatory authority that reviews the products, be it vaccines, therapeutics, or diagnostics. And so we're responsible for ensuring the safety and efficacy of vaccines in this instance, and working closely with our partners that are shown here at WHO, UNICEF, CEPI, and Gavi. Next slide, please. And just to close, we have our link to our website here, and we also have in the next slide some brochures and other information that may be useful for you in your consideration and your questions. Thank you very much, and I hope this was helpful.
Thank you so much, John Fitzsimmons, Chief of the Revolving Fund Program for Access to Vaccines. We have laid a lot of information on you guys today. I think we layered it pretty well, though. I think we built it up slowly. That was a lot of information, and I will remind you to please put your questions in the Q&A box. Just remember to put your name and the organization you're representing. We have a couple already, and I think we'll be getting to those after this next topic, which will really be done kind of like a Q&A as well. I told you we have a special guest. He is not with PAHO, but he was happy to join us to talk about this very important topic. He is Dr. James Hamblin, and he's a staff writer with The Atlantic, but he's also a board certified in public health and general preventative medicine. He's a staff writer at Atlantic magazine, where he served for 6 years, also as a senior editor, and his work has appeared in the New York Times, Politico, NPR, The Guardian, The Washington Post, and many others. He is the author of If Our Bodies Could Talk, Doubleday 2016, and Clean, published by Riverhead in 2020. He has spoken at TED Med, South by Southwest, Aspen Ideas Festival, and many more. And we are very, very pleased that he was able to join us for this session. Welcome, Dr. James Hamblin.
Thank you for having me.
No problem. Well, I'm happy to talk to you because it seems as though we did kind of switch the roles. So you were in public health before and then ended up in communications. Is that right?
I was actually in radiology, and then I started doing journalism, and then I went back and finished up training in public health and preventive medicine, got my MPH after
So I was the opposite. So I did communications and fell in love with public health and ended up in the same place as you. So we're very happy to have you here to talk to us today about this very interesting topic. I just wanted to ask you, what have you gained from what you've heard so far? Did you learn something new today as well?
Yeah, I think everything I heard was new. You know, I keep an eye kind of on what will be of interest to General Interest Magazine, primarily US audience. And so I do miss out on some of the more policy heavy conversations, because I kind of, you develop this sort of filter for what is going to be important to your audience, and how do you reach them. And that's not to say that the higher level stuff is not important, but it's hard to, like, we're working at a different level of conversation here, I think, generally.
Yeah, it's true. And that's why it's so hard, because people are filtering their information. They get information from so many different sources. So what do you consider to be the media's role in informing people about vaccination?
We're just truth tellers. That's where I'm in an interesting position, because I do have a sort of dual obligation to, the practice of medicine and whatever codes of conduct and ethics and goals we would have. They're very rarely in conflict with, journalistic ethics. I think I'm in a fortunate position to be able to sort of contextualize and, we're telling stories that we've never really been able to tell before about vaccine development in real time, and in a degree of complexity that a lot of the public wants. Like, even general interest people who are no scientific background, they're not doctors. And there might have been a time a couple of years ago when reporting on a single adverse event in a vaccine trial would have been considered anathema, because you would be considered to be, you have to think about the narratives you're fueling and the context into which you're reporting that, and you'd say, why are, vaccines are so generally safe, why are you highlighting this one adverse event? But now I think there's an appetite for people to really understand, yes, there are occasionally adverse events, and the best we can do, for the media can do, is help bring transparency to that process, because there are going to be a lot of people out there who really want to crunch the numbers for themselves. They want to look at all the data. They want to, these are smart thinking people, who are not going to accept the vaccine is safe or the vaccine is not safe. They're going to want to, you have lawyers, you have engineers, you have people who might not be doctors, but who are going to be deciding for their family, for their kids, for themselves. And they just really kind of want transparency. And so I think that's what the media can do. It's kind of, you keep a close eye on your audience and their level of interest. It doesn't mean you need to write 5,000 words about every single, ongoing trial, but you have to give the appropriate amount of context such that people aren't freaking out when they hear about something negative, and they also aren't getting, undue hope about some positive finding. You're trying to be careful that you're not implying that, say, a vaccine is around the corner because there was some good outcome in a phase 2 trial, ultimately, and keeping in mind that ultimately most people are reading and listening and watching for that bottom line, okay, this is an interesting finding. I'm glad that worked in this specific trial, but when is the vaccine, when can I personally get a vaccine? So I'm keeping in mind, that is really what people are reading for, and I don't want to mislead in one direction or another.
So you said a number of things, but what would you say is the most important aspect to consider when covering vaccination topics? Is it that context?
I think so. I mean, if you take for granted that the truth and, that you're firstly just trying to inform people that you are not, I'm not an actor. I'm not a pro-vaccine person here. I'm not here to debunk, I'm trying to tell people what is happening in real time. And the challenge for media is knowing just how much context to include and what is relevant to include, because you're always limited for space and time. You're working quickly. You can't include everything that you'd like to say. And kind of bolstering your work to know that, things spread around the internet kind of as little islands right now, and you don't know who's going to be reading it. And that's unfortunate because you can't assume a level of scientific literacy in a way that you could in a time when you knew pretty much exactly who your subscribership was, or that some people might on their social media channels. You kind of know who's going to be reading what you get. So you kind of, you realize you can't talk to everyone. If you try to talk to everyone, you're talking to no one, but that you are creating something that if you imagine it in the hands of someone who is very extremely scared and paranoid and gonna be prone to kind of freak out, for lack of a better term, that you're not,
Your tone.
Yeah. While at the same time realizing that you can't, you can't speak to everyone. In my case, I'm thinking of speaking to people who are kind of college educated but are not in science and medicine, and so I think I realized sometimes is landing in the hands of other people who either find it, have PhDs in this and find it comically simplistic, and others who find it inscrutably wonky. So kind of just trying to make sure you reach your target audience effectively, and that you're not misleading anyone by the context you choose to include.
I think perhaps it may be helpful to not do a one story. Perhaps you need to go at it from different directions for different markets, for different platforms. Yeah.
Yeah. I mean, I think that's why we need the whole, community involved. That, as it's like with the science of behavior change, people are going to get this ambient information from mass media outlets, but it's unlikely to change anyone's mind. One thing that they read in, the New York Times or the Atlantic, it's kind of, if they're an extremely vaccine hesitant person, it's going to take a long conversation with family members or a doctor, a physician, or someone who they know and trust, who's ultimately going to tip them in one direction or another. So all that so it's a constant conversation. Ideally, you're hearing the feedback that you're getting from your audience, and then when I write something, or when there's something in the newspaper, when there's something in any national outlet, that everyone who's sharing that is adding context to it as well. That if you don't have to be a professional journalist, you don't have to work in the media to send out an email to your family, to your networks, to your patients, to tweet something with one sentence of context, to put it on Facebook with a few sentences of context, and that can completely shift the perception of an article that in isolation might have sounded totally reasonable, but if you send it out saying this is an extremely important study, or this is completely bogus, ignore it, that is going to completely reframe whatever I was trying to say, and people are going to trust the person who sent it to them.
Right. Now, you talked a little bit about those short headlines and how far they can go. What advice would you give to editors who sometimes have usually have the final decision on headlines?
In my experience, editors I've worked with are great. That, especially in a moment like this, you realize the stakes of any potential misread on just a headline. I think the ethical assumption is usually that you can't tell a whole story in a headline. Obviously, if you could, it wouldn't be a story. So you don't try to do that, but you have to realize that many, if not most, people are going to be reading the headline alone, and you try to make sure that it's not at least easily misread or misleading when taken alone, while also realizing that it can't tell the whole story. It's by definition like the most massive oversimplification.
Right. One of our questions has already, from one of the journalists in Trinidad, has already talked about anti-vaxxers and how you bear that in mind when you're writing. How would you handle misinformation and rumors about vaccines, COVID-19 and others, when you're tackling it in a story?
So there's an ambient.
Do you actually say what they say? Do you quote them, or do you not?
There's a certain level, and I don't know the answer to what that level is, when below which you ignore it. You don't, you can have this amplification effect. There's this great example that I use in my class of when Donald Trump said that windmills cause cancer. That was not something that anyone thought. And because there was this echo chamber effect of everyone making a big deal of it, that's now stuck in the cultural ether, where it's quite possible that 5 years from now, if you go survey people on the street, true or false, windmills cause cancer, enough of them will say, oh, I think I remember something about that 10-15% might say, yes, there is a link, so the best course of action would have been to simply ignore it. Depending on your audience, depending on the stakes of what's being said, at some point you need to address it. And then, you can take different approaches, which ideally you're not simply repeating the phrase. You're trying to use it as an opportunity to turn in another direction. I think we've done a terrible job with vaccines and autism. Like the constant repetition of vaccines do not cause autism. Vaccines do not cause autism, is just enough. Scared parents are making that decision based on some feeling that they have that this is unsafe, and something stuck in their head about that association. And probably a lot of us have made it worse. So you think about something like framing it as just like vaccines are safe in the context of a long article that discusses, immune responses and the effect on the nervous system and developmental phases and whatnot, for people who really want to get into it. But that, at the basic level, you're kind of reinforcing the message you want to be getting across, not debunking the thing you don't.
Right. So you would say anti-vaxxers, quoting them, it really depends. It depends, and to what level you quote them.
You know, yeah, I think
that amplification.
you're almost, you know, it's almost impossible to change someone's mind with an article. You change someone's mind with a conversation, you know, over a beer, over lunch. This has to be someone you trust, you build a rapport with, you have a conversation, you hear what their concerns are. You know, this is why we need doctors practicing to talk to people who are vaccine hesitant. I don't think any article ever changed people's minds. So when you do address those sorts of concerns and theories, I think you're trying to speak to this vast middle, you know, the not anti-vax, but what we might consider vaccine hesitant, the people who've heard these things. And there's a rumor out there about a particular vaccine or a particular side effect that has become pervasive enough that we should address it. And we should, you know, not in a mocking or dismissive way, take seriously the concerns of these people who have the concerns, let them, you know, speak for themselves. So it doesn't sound like there's some sort of cover up, but clearly the weight of the story is such that there's a little bit where people have gotten to make clear their feelings, and then there's a much larger weight of it, which leaves the reader understanding the weight of the scientific evidence and consensus, and is not misleading like a 50-50 both sides, you know, type story.
Well, we probably have just less than 5 minutes left. I have so many questions I could ask you. What would you say has worked? And please be honest when covering COVID-19 vaccines, and what hasn't worked.
I haven't covered the vaccine specifically. My colleagues have done more than I. We've talked about it on the podcast. I'm covering the pandemic generally. And, you know, we don't have measures. We don't know what's working right now. I think it's a wonderful time to you know, break from the false binary that we had with just having to say, you know, vaccines are safe. Like that you're either pro-vax or anti-vax. I think all of us who, you know, understand the complexity of any medical intervention, that nothing is perfectly safe, that it's a much more nuanced and interesting and intellectually stimulating conversation to have, and we're getting to actually have it now. So everyone's learning at the same time. People are learning about trials, people are learning about distribution patterns and thinking about these things, and it's a wonderful time to engage and to use this as learning opportunity to say, you know, let's go back and look at HPV or MMR, and don't you feel much more confident in that now that you're considering, you know, that next year you might be taking a vaccine that no one's ever taken before, and you're willing to do that. Those decades of evidence on these other vaccines seem a lot more convincing to you now, probably, right? But I don't know. We'll see what has worked. Like, obviously, everyone's trying to walk this really delicate line of not, you know, of moving quickly without putting something out there that could do permanent damage to the credibility of all vaccines. You know, if there's something on the market that people are pretty reassured is safe, and then there is some unexpected side effect, you know, I think that could do damage across the board. So yeah, the job of media is just to be just honesty and transparency and accurate assessment of risk. And I would not go out there and say, like, this vaccine is safe, everyone should take it. I'll get out there and say, here's what the data are, you know.
Okay. Who are your go-to sources about vaccines? How do you check your source statements?
I am pretty biased toward just people with academic credentials who study vaccines and infectious diseases. I kind of rely possibly too heavy on institutions to do the vetting for me.
Okay. And could you tell us maybe what has been one of your most successful stories related to vaccinations and what made it so successful?
Yeah, I mean, the first story that I wrote was in about the coronavirus was in, not the first story I wrote. The first story I wrote about the vaccine was in February, and it was called "You're Likely to Get the Coronavirus," and it was charting out this pathway of saying, you know, there's not going to be a vaccine, like, even at the fastest possible rate. Like this looks like it's going to become a pandemic. Here are the companies that are starting to look into vaccines, but it's going to take a lot of time. So this is going to spread like widely, and basically charting out why it needs to take that much time. And I was just trying to set expectations, you know, appropriately then. And, you know, I mean, people are still thinking or believing our president when he says there's going to be one next week, and which he's been saying for months. You know, I don't have that big of a platform, but for people who genuinely wanted to know and wanted to read 3,000 words on it, I just tried to really lay out like what the process would be and why it will take a long time. So yeah, that's the one that, I don't know. I think everything I've written since then has been kind of just sort of reiterating, you know, the news cycle moves so fast. You kind of do find ways to, you have to find ways to kind of make the same points over and over again, or tell stories through slightly different lenses.
Right. Well, I want to thank you very much, Dr. Hamblin. I hope you'll stay on the line in case there are any other questions for you. There is one that I'll probably lead your way, but I want to also include our technical experts in the conversation at this time. We do have a question that I'll give you a break, Dr. Hamblin, and go to Dr. Lucia de Oliveira with the first question that came in pretty early, just in case the journalist has to leave. From Trinidad, the question is, with respect to the symptoms experienced when persons have been vaccinated, is there any evidence to show that persons can infect others with germs from the symptoms that they're showing? So you have you've been vaccinated, you get a little bit of a cold. Can you infect someone if you were to cough or sneeze on them?
No, you can't infect someone with the vaccine. If you have some kind of, for example, little fever or cough or some, because it is an effect of the vaccine, because the virus or the bacteria is working on your body, you are not going to infect anyone. But as I mentioned during my presentation, if the person got the vaccine yesterday, for example, and today he starts with high fever and cough and feeling bad, and it's like a flu, it's because this person got the flu before to get the vaccine, and this person can infect another person. Did I answer the question?
Yes, I think you did. This one is also for you. Sorry. Yeah. Many people are concerned that vaccines add a little virus or germ to the system, and they may not understand that the full-fledged virus that is being, it's not the full-fledged virus that is being administered, but actually a laboratory controlled germ that's been modified to get the immune system prepared to fight it off. Is this correct? Is that person explaining it? Because, you know, as media people, we have to be experts for a day on a topic. Is that a good explanation of what it is?
Yeah, I think I also showed in my presentation very briefly, all the vaccines are made with killed virus, for example, attenuated virus, or a part of a protein, or now the vaccine for COVID, some of them with nucleic acids. So it's part of the virus of the bacteria. So it's not the virus complete which caused the disease. So this is not the vaccine. It's also modified in some technology, in some platform that they are going to use in order to develop the vaccine.
Okay, thank you very much. This one was really going to be for Paho, and I think I answered it in that the question and the statement really is, as media people, we have to relate this confidence in vaccine to our audience, but with all the anti-vaxxers consuming social media, will Paho be working more vigorously on health education to demystify the myths about vaccination? I think I kind of addressed it in that, yes, we do know this is something that we have to work very hard on. I don't know if there's anyone from Paho that would also like to say something about this, and maybe James, if you would also want to talk about demystifying myths through reporting.
Hi, hello. Yes, I say Paho is working very hard with this. We have obviously a plan how to reduce this hesitance about the vaccination. We have an immunization communication plan to work in Paho. But for this, like James said, it's not enough to have only a plan or to have the role of PAHO. We need to involve the ministers of health in the countries. We need to involve the social society. We need to involve the newspapers. We need to involve the professionals of the communication. This is the reason that for us is very important the role of the person that is attending this meeting, because the opportunity that you know the information, you can to understand the information, and you help us how to transmit this information to the people to get confidence in the vaccination. Over.
Dr. Rees, there's also a question here. Someone wants to know, why are the numbers of unvaccinated children growing? I'm not sure if that's specific to COVID-19 or before. Why are the numbers of unvaccinated children growing or increasing?
In this moment, like I show, it's we have a really a big impact in the coverage and the number of doses that we apply, link it with the problem that we have in the pandemic, because we have some measure to stop the opportunity that people to go to the clinical or the health centers, etc. No, obviously this is impact not only related with the functionality of the health centers. It's because the people don't like to go to the out of home. No, it's one point. But unfortunately, in some countries in the America, since some years ago, we have a reduce in the coverage that we have. No, and this is principally in my presentation. I show the last slide that is not only if the health centers or the health services working or no. It's more social activity, because we are now with the urbanization, with the disaster, with the crisis, social and political crisis, the economical crisis that we have in the countries, etc., etc. And obviously, this is affecting the program. No, it's not only the program, it's all the social environmental that we have now.
Thank you very much. Dr. Lucia de Oliveira, a question for you. How can COVID-19, I would believe they mean vaccine, be safe if they're going to be developed in record time, when generally a vaccine development process often lasts 10 to 15 years?
This is the question that always comes up. There are protocols right now in WHO, in FDA, and the EMA in Europe, considering what are the minimal criteria that these vaccines have to reach in order to be approved by these agencies. Also, you have to say that the other vaccines that take around 10 to 15 years, some of them, none of them had what today we have with COVID vaccine. Many manufacturers, billions of dollars in this production. So all the community, scientific community involved in this production of this vaccine. So we don't have to be afraid that these vaccines that are going to be approved are going to be approved without the minimal criteria in terms of the efficacy and safety.
Thank you very much. And we definitely saw the process. So we know the process now that a vaccine goes through, whether it be 10 years or whether it be 1 year. So thank you very much. Mr. Fitzsimmons, for you, the 10 countries that are eligible for the Gavi support, how were they selected?
Yes, thank you for the question. It's a good question. And approximately 6 of them were former Gavi countries, low-income countries: Haiti, Honduras, Bolivia, Guyana, Nicaragua, and I'm missing one. And many of those, with the exception of Haiti, have transitioned from being called Gavi countries, but they're still in that grouping. And then the additional 4 countries that are shown on the list are considered IDA eligible countries. So this categorization of countries, AMC countries, and globally, we're talking about 92 countries, India, Indonesia, and many others from Africa included in those 92. 10 are from those from this region, and the stratification is around that the World Bank classification. Over.
Thank you very much. And Dr. Ruiz, in terms of the vaccine trials, are there any Caribbean countries that are taking part in the vaccine trials at this time?
No, in this moment, no. No Caribbean countries are involved in this clinical trial. And there are some countries in America involved in this clinical trials in relation directly with the producers. And if, for example, it's involved Mexico, Chile, Argentina, Brazil, no, and some of the countries that involved, but no Caribbean countries yet.
Okay. Just to let you all know that we will be hosting a repeat of this session in Spanish next week. The registration link is in the webinar chat, so you can definitely look out for that. It will be next Friday at 2 p.m. From Trinidad, now this is towards you, Dr. Hamblin. They say that you raised a critical point and reinforced the reality that media people are not scholars in the field of medicine, yet they have to come across as an authority on reference, and people rely on this information. So they say it is imperative that the authorities on COVID vaccines are visible and have as much or more presence than the fake news creators or the mischief makers. He says that you seem to be an appropriate go-between to translate the medical jargon into a language that the layman can absorb and believe. The question, has this kind of service been a consideration by PAHO to engage persons who can translate the jargon and pass it on to the public and even some media houses? So that's not really a question directly to you, but maybe you would like to comment on being able to translate the jargon. I know there are a number of communicators at PAHO who help in translating what these technical experts say, and I am one of them, but they are also trained in communications as well to some degree. James?
Yeah, and you know, I think avoiding jargon, translating jargon is sort of the bare minimum. It's something that actually I think every scientist and doctor should be trained in, because we all know how to not speak in jargon. We all did it before our training. We should all remember how when speaking to media, when speaking on social media platforms, when speaking, in forums where it will minimize any potential for miscommunication on the part of a journalist. You know, many journalists are brilliant, excellent science communicators. They can speak both languages and translate perfectly. Some of them, though, it's, their first day on the job and they don't know some of the jargon and something gets lost in translation. So the doctors and experts can avoid that jargon in the first place. That leaves the journalist with more time and energy to do what journalists do so well, which is tell stories, which is that, the part that's been missing from this discussion that I've heard so far is a lot of people do have the facts, but they, you act on emotion. We act on what we remember and what moves us. And that comes down to storytelling. And so the job of the journalist goes far beyond translating and avoiding jargon and actually trying to make things, pop and stick in people's minds.
Okay. I think we're just about close to wrapping up. I just have one last question here that I'll throw to anyone at PAHO. Does PAHO have a fact-checking desk? I think the fact-checking desk is call us, email us, write us, and we will provide you with the information. But anyone from PAHO can answer that one. Any takers? Anyone from CMU want to say? Go ahead.
Oh, we don't have exactly a check-in test, but we have a lot of information in the web of the PAHO, that it's open for all the people to go and to check the information, and it's the process that we have now.
Yes, and there's lots of information.
Lisa,
Sure.
Thank you. Maybe to add to the information that we have questions and answers, and many questions like this that we are discussing today, and you can go to our webpage and review that. We are trying to post it periodically based on the new information that we have. Thank you.
Thank you very much, Dr. Alba Maria. Yes, there's a lot of information on the regional page, on the PAHO Caribbean page as well. There's tons of information. And if you still cannot find the information that you need, please reach out to us. Just look for us online. There's always an email where you can reach out to us for more information. I think we've come to the end of our session. And I really want to thank everyone for joining us. Our special guest today has been Dr. James Hamblin, staff writer of The Atlantic. I think he brought a refreshing perspective on how to cover these very interesting topics. Then also want to thank Mr. John Fitzsimmons for talking to us about the Kovacs facility, the revolving fund, and shedding some light on how that all works, how we are preparing for the COVID-19 vaccination with Alba Maria Rotero, regional advisor. We also had a session on vaccine basics, how they work, their safety, their efficacy, and then we heard about immunization in the Americas over the past couple of years and where we are now. And of course, I want to thank Dr. Jarbas Barbosa for welcoming all of us this afternoon. I hope you learned something from the session. I certainly enjoyed being a part of it. And I want to say thank you to everyone who joined us. And we hope for those of you who speak Spanish, if you would like to join us again next week, Friday at 2 o'clock for another interesting session. Thanks so much for joining us today and have a wonderful weekend. Stay safe.
Thank you.
Thank you. Good job, Lisa. And thank you, James, for participating.
Thanks.